Okay, we're starting soft spherical contact lens fitting. We're talking about spherical, not about toric contact lens. Yes, not about soft toric, not about RGB toric. We are today going to talk about contact lens fitting. So we're basically starting contact lens fitting chapter. We will talk about soft spherical contact lens fitting. Then we will talk about RGB spherical contact lens fitting. Then we will move towards toric fitting. Yes, let's move. So what is soft contact lens? Soft contact lenses are made of soft, definitely flexible plastic that allows oxygen pass through the through the contact lens to the cornea. So soft contact lenses are made up of basically HEMA. Yes, and nowadays there's silicon hydrogel materials that permit higher amount of oxygen, and definitely the silicon hydrogel can be wear as an extended wear. An alternative name of the soft contact lens are hydrophilic contact lens, sometimes gel contact lens, sometimes limbal contact lens, which is definitely funny name. Hydrogel, flexible, pliable contact lens too. So let's move further. What are the basic advantages of soft contact lens and what are the disadvantages of soft contact lens? We have to know these things. Yes. So first and foremost, which is very important advantage, is initial comfort and ease of adaptation. That's very first. Soft lens are made of a polyolefin material and that conforms to the eye surface, so most patients find themselves comfortable. This is one of the major advantages. Otherwise, I don't think RGP is like literally very good material, but at the same time comfortable. That RGP is not comfortable, especially corneal lenses are not comfortable as compared to soft contact lenses. So soft contacts are comfortable immediately. That's a very 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 big advantage of soft contact lens. And definitely soft contact lens adapted faster than compared with corneal, especially RGBs, corneal RGBs. Yes, handling for new or intermediate wearers. Softer, larger diameter are easier to insert and remove. Yes, definitely, but it's not easier to insert and remove as compared to corneal lens. But yes, it's easier for many patients and for giving intermediate or part-time wearers. So soft contact lenses are very useful intermediate or part-time wear. So lower short-term awareness and age sensation. Definitely, I have already talked about comfortable because age awareness is very less as compared to corneal lens because of soft lens draped over the cornea, whereas typically do not feel the lens edge and experience lens awareness. So one of the major contributing factors whenever we are talking about contact lens is definitely sensation of lens edge, and especially against the lid, the conjunctiva of the lid. Yes, so basically the interaction between edge of the contact lens to the conjunctiva, especially upper palpebral conjunctiva, and that gives the lens awareness most of the time. But yes, definitely in case of soft contact lens it's way lesser in compared to corneal lens, RGP, corneal RGP lenses. So better tolerance for sport and impact of running. Yes, soft contact lens do not dislodge easily as compared to what do you called corneal RGPs. Yes, and are likely to cause foreign body sensation when deprived hits of eye. Yes. So cosmetics and availability options. Soft contact lens came to daily disposable, monthly disposable, even toric, multifocal, tints, disposable format, which is basically availability options in case of soft contact lens is way, way, way higher. Yes, nowadays RGBs is also better. So what about the why soft lenses are worse? So there are a lot of things why soft contact lenses are worse in compared to RGBs. First is optical quality and sharpness. RGB hold their shape and make corneal irregularity. So basically corneal irregularity because of tear lens, RGB holds that. RGB itself has shape shape that it can hold, and that's why RGB has given much better vision. So that's why RGB gives sharper and more stable vision, or especially for those whose cornea is irregular, like keratoconus or high astigmatism. Soft spherical lens drap over the cornea and cannot reliably neutral the irregular astigmatism. For irregular astigmatism, rigid contact lens are like literally very good solution because of the tear lens. It masks the irregularity, not just irregularity, it marks the high order aberration. Yes, that's why vision, it's always RGP is much better for vision, sharp vision than soft contact lens. And again, deposit wettability and tear film interaction. Soft lenses are especially uh, absorb tear protein, lipid, and more prone to surface deposit. It's always there. In compared to RGPs, soft contact lenses are always more prone to deposits. But at the same time, RGP resist for the deposit. And oxygen physiology for some fits, definitely, if we get rid of silicon hydrogel, then hydrogen lenses are not good as compared to nowadays RGBs. Nowadays silicon hydrogen and RGBs, they are very good. Yes, so RGB thin, and nowadays material like fluorosilicon acrylates, they are very good in passing oxygen. At the same time, RGBs has another one of the way to pass oxygen is to tear exchange, which is another very important factor. That's why uh, do not block the tear exchange. But soft contact lens tear exchange like literally like 1% or 2%, but RGBs is like literally 15-20%. Yes. So long-term durability and cost per lens. Soft disposable are convenient but recurrently purchased, because soft contact lens we have to purchase frequently. But at the same time, RGBs are more durable can last for years, like extremely high oxygen high decay lasts for 1 year or 18 months. But uh, many of the RGB if handled good, then it can last for 2 years. Yes, that's why for the long term it's always economical. So ability to correct certain high order aberration, I have already talked about it, because RGB create tear lenses, and that tear lenses will definitely help to correct high order aberrations, which is very fantastic point that every optometry student must know. So that's the beauty of RGB. So in case of RGB, we always have to understand this small concept. RGB makes tear lens, and tear lens definitely helps to hide irregular astigmatism, high order aberrations, and all these things. Yes. Okay. Risk for dislodging versus foreign body resistance. So that's definitely trade-off. Yes, risk for dislodgement versus foreign body resistance. What is the trade-off? Let's discuss. Soft lenses are less likely to pop out, definitely, but they can trap the debris, isn't it? But at the same time, RGP moves with each eye, allow the tear exchange and flush the debris. That's what, and at the another point of view, RGPs definitely have more risk for dislodgement. But at the same time, if some foreign body comes under the RGP, then there is high chance, because of blinking and tear exchange, that foreign body flush out. That's very definitely. That's why the point is risks of dislodgement versus foreign body resistance trade-off. Yes, that's the point. So soft contact lens requirements. What are the requirements of soft contact lens? So soft contact lens must center on the anterior eye. Definitely centration is important. It must be comfortable in the anterior eye. It must move adequately. Yes, it must move adequately. Movement is very important no matter what. It's soft contact lens. Yes, it's not important like scleral lens. In scleral lens, movement are not that is important, but definitely it's important in soft contact lens, RGB lenses, and so on. So cover the cornea in all eye position. Basically, we want our contact lens covers our eye in all position, not just in a primary gaze, but no matter what. If I move into right or left, up or down, whatever. Soft contact lens performance requirement. What are the soft contact lens performance requirements? Is it must produce good and stable vision. We want our contact lens give us good and stable vision. Provide minimum physiological disturbance. If it does maximum physiological disturbance, then what happens? So there is a grievous injury to cornea. What do you mean by that? Cornea is swelled, endothelial cells number decreases, even its sensation, corneal sensation decreases. There are a lot of things that happens. Yes, we don't want that things to be happen. So that's why what we want is provide minimum physiological distortion. What do you mean by that? We want our contact lens to do physiological disturbance least as possible. So be wearable for practical period. Yes, we want to wear contact lens for practical period, for example 12 hours, you know. And very important point is to be comfortable, which is very important point. If contact lens is not comfortable, patient cannot wear it, then no matter what it's stable or not, no matter what it's practical period or not, no matter what it's physiological disturbance or not, patient will discard the contact lens, and which is not good. So when to fit soft lens, soft spherical lenses. Just remember, we are not talking about toric lens. Yes, spherical lenses. So first is, if everything is good, definitely soft spherical lens is first choice. It's definitely for spherical refractive error less than 0.75 cylinder. If cylinder is greater than one diopter, then I suggest not to think about this rule. Yes, we have already discussed about this rule. Not to think about this rule. If it's greater than one, we need uh, toric contact lenses. For comfort issue, definitely soft contact lens is better. If RGB is not comfortable for the patient, patient cannot tolerate RGB discomfort, that initial discomfort, that patient has to do the adaptation period, pass the adaptation period. If patient is not comfortable, then definitely you have to switch from RGB to spherical soft contact lens. Extreme refractive error including aphakia. Yes, in case of aphakia, it's better if we can prescribe high decavity, what do you call, soft contact lens, especially soft contact lens for high power, high FAK, yes, lenticular contact lens. And low prescription, definitely soft spherical contact lens. Significant corneal astigmatism, but manifested by spherical prescription. It means, basically, it means, what do you mean with significant corneal astigmatism, but manifested by spherical prescription means internal astigmatism corrects the corneal astigmatism. That's why cornea has astigmatism. At the same time, when you do subjective refraction reveals spherical power. So, in at that particular regard, spherical soft contact lens work well, but spherical RGP it do not work well, because at that period, if you put spherical RGP, then internal astigmatism manifest, which is not good. At that particular case, this particular case, you do not use spherical RGP, which is actually plays against the patient. So that's why in this particular case, you have to prescribe spherical contact lens. So contact lens fitting, as we know, there are two types of fitting. Yes, one one type of fitting is empirical fitting. Another type of fitting is diagnostic fitting. Empirical fitting means, what is the difference between empirical fitting and diagnostic fitting? So empirical fitting, it involves the fitting of contact lens based on total diameter, keratometric reading, back vertex calculation, and manufacturer guide without the use of trial lens. That's the main. Other things are exactly same. In both cases, we measure keratometric value, we measure spectacle power, we measure corneal diameter, we measure everything. Yes, but we do not do trial of contact lens in empirical fitting. But in diagnostic fitting, definitely term diagnostic, we do trial of contact lens. Yes, in fitting based on, basically we measure everything, keratometry, diameter, back vertex power calculations, and everything. And according to manufacturer's guideline, we do trial of that contact lens before prescribing. So basically, diagnostic fitting means we do trial of the contact lens. In empirical fitting, we do not do trial, we direct prescribe. So, for example, if someone has -2 diopter spherical, so we don't think much about it. Yes, we directly, we don't have to do vortex calculations and all these things. We do simply, what do, we do keratometry value and all these things, tear volume and all this, and then we think about material, and then we prescribe simply, because soft contact spherical contact many times fit normally if cornea is normal. So we do not think about trial. Yes, so empirical fitting and diagnostic fitting. Okay, so contact lens fitting, complete process of soft contact lens fitting can be divided into three segments. What are the three segments? So baseline measurement. What do you mean by baseline measurement? Baseline measurement means the previous video that I have made. Yes, it's basically preliminary examination. What are the examination that we have to do before doing trial lens. And the second part is trial lens parameter choice. Then we choose the parameter of the trial lens. Third, we do trial. And on trial, definitely we have a lot of things that we have to think about. Yes. So first is the baseline measurement. We do all the measurement. Then we think about the choice of lens parameter, and then the best lens parameter, the best chosen parameter lens we insert into the patient's eye. That's the fitting. And what do we do when we insert into the patient's eye? We give a few minutes, like 5 minutes in 5 to 10 minutes in soft contact lens for adaptation period. After adaptation period, we want to know how that contact lens goes into his or her eyes. What's the fitting status is fitting is good, it's optimum, or it's loose, or it's tight fitting. So we want to know which type of fitting. We definitely want optimal fitting, isn't it? So that's why these three steps we move on. So what do we do in baseline measurement? Slit lamp examination is inevitable portion. Horizontal iris visible diameter, based on it we select diameter. Many times it's like simple, yes. And papillary fissure, it's also important because based on this there can be fluctuation in diameter of contact lens. Pupil size measurement is very important for the size of BOZD. Keratometry is very important for the best curve selection. Additional tests there are for what are the main important factors upon which we choose lens parameter. Base curve definitely which depend upon the radius of curvature of cornea, total diameter, lens thickness, optic zone diameter, which is depend upon the pupil size, water content. Definitely, it's depend upon one of the condition is patient's dry eye. Yes, and fitting we see centration, coverage, movement, lag, push-up test, comfort, age, modification. These all things we see in the fitting assessment. Yes. Okay. Let's move further. So, what are the baseline measurement? It's simple slit lamp examination to identify the pathology of eye and surrounding structure and observe accordingly. So, what do you mean by that? From slit lamp, we want to see if there is anything contraindicated condition in eye or not. Like, for example, infection, for example, blepharitis, for example, maybe when gland dysfunction, for example, sty, or many other things. Yes, we just wanted to know what is the status of eye. Basically, eye is good or not. If there is anything um, like recurrent pathological phenomenon is going or not. Okay, so I have taken this from this paper, and so 2002 from essential contact lens practice. uh, okay, so in that paper, so slit lamp findings and appropriate action prior to fitting the contact lens, what are these? For example, these are the structures we have seen. Yeah, if eyelashes and eyelid margins have blepharitis, what do we do? So we have to resolve blepharitis before contact lens fitting. Entropion, ectropion, definitely, if it is there, we must refer to the ophthalmologist. Sty, usually self-limiting, but we must be cautious because it's infectious condition. Maybe when gland dysfunction, definitely we want to do hot compression prior to fitting, and we want maybe when gland dysfunction must go from that eye. Yes, Calagian, refer for the removal before fitting because we must be cautious about these things. Many of the optometrists do not being cautious with eyelashes and eyelid margin. I think eyelashes and eyelid margin are most important structure we have to see before prescribing contact lens. Okay, so palpebral conjunctiva. What are the things that are important in palpebral conjunctiva? So if there is hyperemia, so we must know the cause prior to fitting. If there is follicle or papilla, so depending on severity, lens type, ideally daily disposable or possibly RGB. So basically, we must know what are the cause of follicles or papilla. Then, if there is not severe, then we must be cautious before prescribing contact lens. Yes. So bulbar conjunctiva, limbus cornea, for example, hyperemia in bulbar conjunctiva. So definitely, a certain cause before fitting. Another is pinicula or pterygium. So minimal mechanical stimulus on the tissues, but we must know if pinicula and pterygium is there, especially pterygium. So it affects the contact lens fitting, we must be cautious about it. Yes, neovascularization. We must record the baseline for neovascularization, and we must understand if neovascularization is there, then if we prescribe dk by t of contact lens is very low, like we're literally preventing oxygen from that particular cornea, then it can grow. Neovascularization can grow and it can cause devastating result at the end. So we must be cautious about it. We must record the baseline. We must record that neovascularization, how much it approaches to cornea and how deeply it moves into cornea, and which time zone it is, like 3 o'clock or 4 o'clock or 5 o'clock. We must record it. Even we must draw it. Yes. So staining, we must stain cornea. If there is staining, we must know what are the causes, because staining is there. So we must know the causes. Yes, sometimes it can be devastating, so we must know the cause of the staining, especially in cornea. So opacities, if there is any opacities in cornea, we must record it. Edema, if there is edema in the cornea, then at first we think that we have to stop, and then we definitely move forward if everything is okay. If there is edema, then we must be cautious about decavity of that particular material. We must be cautious about decavity. We must put our best decavity, highest decavity possible. Yes, and definitely we must monitor well in edema and neovascularization and staining conditions. So these are the things we have to take into account before fitting contact lens. It's very important. So what are the parameters and property for the initial lens selections? What are these things? So first, base curve, which is centrally important. Yes, and base curve means what? Determines the lens curvature. And total diameter, which is normally in this range 13.8 to 14.4 mm. And definitely back vertex power. So what do you mean by back vertex power? Corrected back vertex. We have to correct according to the correct back vertex power of the spectacle lens to contact lens, and we have to select the closest possible. Yes, many of the students think that if someone has -5 power, then we can do trial with, for example, -1 DSPS. We can do with a plano, but that's not good strategy. You have to, if you have trial lens, then you must match your trial lens closest possible to this, to that lens which you are actually prescribing. For example, if someone has -5 power and what from vortex distance correction is -4.75 diopter, then if you have -4.75 diopter, you have to do your trial lens with -4.75 diopter. You do not use plus 4.75 or plus 0 or plus minus 0, whatever. So it's not like that. Yes. So replacement frequency, daily to weekly, monthly. Yes, we have all these things. Modality, daily wear, continuous wear, extended wear, or flexible wear. Yes, we know that. Material and oxygen purpose. Definitely we do know decavity of that particular lens, and others definitely there is handling tints and UV inhibitors is there or not. We have to know. So l- these are the things. What are the baseline measurements? As I have discussed, SVID. What is SVID? It's horizontal visible iris diameter, and SVID is important for soft contact lens, and its soft contact lens diameter, and its rough idea is always that SVID plus 2 is total diameter of that particular soft contact lens. Yes, so normally we can do measurement from corneal topography, Bornese scales, slit lamp, normal millimeter scales can be used. Yes. So another is palpebral right? It can be again by slit lamp or scale. And what about the palpebral right? Where it is being used? Higher the palpebral right of the patient, suggested for larger the diameter. It's very simple, like directly. If palpebral right is larger, then diameter must be larger. That's simple. If it is smaller diameter, we must use smaller diameter contact lens. It's very simple, straightforward relation. Yes. So pupil size, uh, why it is important? Because in regarding pupil size, Its rough idea is optical zone is pupil size in dim plus 2 mm. It's better. Optical zone, especially front optical zone. Yes, it's a rough normal pupil size in photopic, mesopic, and scotopic. We don't care about mesopic. We really care about scotopic because male scotopic is 5 point something. In female, this is a rough idea taken from this paper. But what is the rough idea that you have to take into account in your brain? So it's basically optical zone, especially optical zone front optical zone diameter must be pupil size at scotopic plus 2 mm. That's a rough basic guideline. Okay, so what are the most important measurement is, I think, base curve of the soft contact lens, and base curve of the soft contact lens depend on the radius of curvature. So so that's it. Yes, so additional test is iris color, tear film, which is most important. Yes, normal tear breakup test, meniscus test, we have already discussed about it. And the best curve selection. See, this is very much important slide in presentation, how to select the appropriate best curve. And many of the entrance examination asks the same question, and people get confused with this best curve selection of soft contact lens with RGB contact lens. Don't get confused here. Okay, we are talking about soft contact lens, and it is the radius of curvature back surface of the contact lens that's sometimes called base curve. So it's roughly, it's called the, if there is an average k, then your base curve must be flatter. Means what? You add, yes, base curve means you have average k plus you add 0.6 to 1 mm roughly. Flatter means that, yes, you add. Or another, you add directly 0.7 to the flattest k. So you must distinguish that you have 2k, right? One k1 and k2. K1 is always flatter, yes. To the flattest you can add 0.7. That's another guideline, which is very simple guideline. Yes, it's guideline for thicker and low water content. One guideline is for average. Average means what? K1 plus k2 divided by 2. Then you add roughly 0.6 to 1 mm. With the flattest k, you add 0.7. Okay, that's another thing. So add 0.6 to 0.3 to 0.6 mm for standard flexible material. So see, if soft contact lens is too much thinner and high water content, it means its modulus of rigidity is very low. It means it's very flexible material. At that particular point, we choose a little bit more flatter. Yes, that's the condition. Okay, so that's it. These two are very important. With flat k, you'll add 0.7. With average k, you add roughly from 0.6 to 1 mm. Yes, flatter. So that's what I already told you. Okay, so basically, what do you mean with base curve? See, for example, if 44 diopter k1 and 46 diopter k2, on an average 45. If 45 diopter is converted into mm, it's 7.5 mm. Then what do we do with the average? We add 0.6 to 1 mm flatter. So in this example, we add 1 mm. So that's, we have average 7.5 plus 1 mm, and we have base curve now 8.6 mm. Now we finally choose base curve of 8.6 mm. This is how you do calculations whenever you are in the OPD. Yes. Yeah. I think I will start from this slide. In the next video, it's already like 30 minutes. So I think this done. Cheers.